This video will address pancreatic head removal with surgery called eponymously as the Whipple procedure. Its technical name is pancreaticoduodenectomy. Surgery for tumors in body and tail are covered in the following video. Hello, this evidence-based content is prepared by Saboor fellowship-trained consultant surgeon, and if you or someone you care about has been told they need a Whipple procedure for a pancreatic tumor, you're in the right place. I know hearing terms like pancreaticoduodenectomy can feel overwhelming. This is one of the most complex operations in surgery. But today we're going to walk through exactly what this surgery involves, who it's right for, and what you can realistically expect during recovery. The Whipple procedure, formerly called pancreaticoduodenectomy, is major surgery designed to remove tumors from the head of the pancreas, the most common location for pancreatic cancer. This operation removes the pancreatic head duodenum, the first portion of your small intestine, your gallbladder, part of your bile duct, and sometimes part of your stomach. Your surgeon then reconstructs your digestive system so you can still digest food and produce the hormones you need. Mortality rates have dropped from over 15% in the 1970s to less than 3% in modern high-volume centers. There are actually two versions of this operation, the conventional Whipple and the pylorus-preserving Whipple. The conventional Whipple procedure involves removal of the pancreatic head duodenum, first 15 centimeters of the jejunum, that's about 6 inches of your small intestine, your common bile duct gallbladder, and a partial gastrectomy, meaning removal of part of your stomach. The pylorus-preserving version keeps your gastric antrum pylorus and the first 3 to 6 centimeters of your duodenum intact. There's good evidence that the conventional approach reduces delayed gastric emptying, a complication where your stomach doesn't empty properly after surgery. However, the pylorus-preserving approach reduces operative time, blood loss, and transfusion requirements. But here's the critical point. There is no survival benefit for either approach. Research demonstrates that both procedures deliver the same long-term outcomes. Thus, the preferences of the surgeon and patient should prevail. One of the most important reasons for improved survival is the greater experience of a more limited number of surgeons who perform the procedure on a regular basis in high-volume hepatobiliary centers. A meta-analysis of 14 studies revealed a significant association between hospital volume and postoperative mortality. The numbers show an odds ratio of 0.32, meaning you're roughly 3 times more likely to survive the immediate postoperative period at a high-volume center compared to a low-volume facility. The operation is primarily for resecting pancreatic cancer of the head or uncinate process. That's the hook-shaped part of the pancreas. Tumors must be resectable, meaning they haven't extensively invaded major blood vessels or spread to distant organs. Your surgical team will evaluate 7 critical margin locations to ensure they can achieve what's called an R0 resection. That means removing all visible tumor with clear margins, ideally with 1 millimeter or more free of tumor cells. For patients with tumors that focally involve the portal vein or superior mesenteric vein, surgeons can perform venous resection and reconstruction simultaneously with the Whipple procedure. When compared with standard pancreaticoduodenectomy, adding venous resection increases the complication rate and has been associated with higher mortality. Portal vein thrombosis, blood clots in the reconstructed vein, developed in 16% of patients at a median of 15 days after surgery. The superior mesenteric artery courses behind the pancreas and involvement typically indicates unresectable disease. Standard lymphadenectomy, removal of lymph nodes, is also performed. Your surgeon should aim to resect lymph node stations 5, 6, 8A, 12B, 112B2, 12C, 13A, 13B, 14A, 14B, 17A, and 17B. Extended lymphadenectomy, removing even more nodes, confers no survival advantage and increases complications, including lymphatic fistula, delayed gastric emptying bile leak, and pancreatic leak. While perioperative mortality in most modern series is less than 5%, morbidity rates remain significant. According to data from high-volume centers, 28% of patients develop one or more severe complications. Here's the breakdown. Postoperative pancreatic fistula. When there is a leak of pancreatic contents from the joint between small bowel and pancreas, see image, this occurs in 23% post-pancreatectomy, hemorrhage in 2.7% delayed gastric, emptying in 6.3% when the stomach is slow to get going, and chyle leak in 6.3%. The list of possible complications during operation and after is longer, only the significant ones are mentioned. Overall, up to 45% patients may develop a complication, including many minor ones, of some description. Dumping syndrome after a Whipple procedure occurs when food moves too quickly from the stomach to the small intestine, causing symptoms like nausea, cramping, and diarrhea, early dumping, or dizziness and fatigue, late dumping. Managing it typically involves dietary changes, such as eating smaller, more frequent meals, limiting high sugar and high carbohydrate foods, and drinking most fluids between meals. Recovery from a Whipple procedure is measured in weeks to months, not days. In large contemporary series, patients underwent 650 consecutive pancreaticoduodenectomies in the 1990s, and the data reveals decreasing length of hospitalization over time. However, even with modern techniques, you're looking at a median hospital stay of approximately 1 to 2 weeks for uncomplicated cases. Most patients cannot return to normal activities for 6 to 8 weeks. If you develop complications like delayed gastric emptying or pancreatic fistula, recovery extends further. Adjuvant chemotherapy should ideally start within 8 weeks of surgery, but it can be delayed if postoperative complications prevent timely recovery. Exocrine pancreatic function, meaning the remnant pancreas' ability to produce enough enzymes, is compromised following the Whipple operation. Research demonstrates that pancreatic enzyme replacement therapy improves fat absorption and nutritional status in post-pancreatectomy patients. You'll likely need pancreatic enzymes with meals indefinitely. Think of these as essential medication, not optional supplements. If you're worried about someone you love, here's what matters most in the first few weeks. Initially, watch for blood loss, undue dizziness or lightheadedness, fever, persistent nausea or vomiting, inability to eat, abdominal pain, or jaundice. These warrant immediate contact with the surgical team. Research high-volume pancreatic surgery centers. Specifically, look for institutions performing at least 15 to 20 Whipple procedures annually. Call their coordinator and ask directly about their annual volume and mortality rates. Prepare a specific question list for your surgical consultation. Include: what's your personal experience with this operation? How many have you performed? What's your complication rate? Which surgical approach do you recommend, and why? What happens if my tumor involves the portal vein? Arrange for extended support at home. Recovery takes months. You'll need help with shopping, cooking, and household tasks for at least 6 to 8 weeks. Line this up now, not after surgery. Clarify your resectability status. Ask: is my tumor resectable, borderline resectable, or unresectable? What imaging findings determine this? Understanding this determines whether you need neoadjuvant therapy, chemotherapy, or radiation before surgery, which changes your entire treatment timeline. Discuss margin status goals. Ask: what's the likelihood you can achieve an R0 resection with clear margins? If margins are positive, what's the plan? This conversation matters because margin status strongly predicts survival. Address nutritional support. Ask: will I need pancreatic enzyme replacement? When does that start? What about insulin? Will I become diabetic? Total pancreatectomy causes permanent diabetes, but even partial resections can compromise pancreatic function. Immediately seek reevaluation if you develop new or worsening jaundice, unexplained weight loss exceeding 10% of body weight, or persistent abdominal pain radiating to your back. These can indicate disease progression. Postoperatively, contact your surgeon urgently for fainting or significant lightheadedness, fever above 38.3 degrees Celsius or 101 degrees Fahrenheit, persistent vomiting, preventing oral intake, abdominal distension, or drainage from your incision. These may signal complications requiring intervention. Trust your gut and get in touch with your surgical team if you are not well. Consider a second opinion before surgery if your surgeon performs fewer than 10 Whipple procedures annually, you haven't discussed surgical approach options, or you feel rushed into a decision. The relationship between surgeon volume and outcomes justifies traveling to a specialized center. The Whipple procedure is complex surgery. Choosing an experienced surgeon at a high-volume center dramatically improves your survival. Your next step: secure a consultation at a specialized pancreatic surgery center and prepare your specific questions about surgical approach, complication rates, and recovery timeline. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.